Kindly go ahead. You can start. Thank you.
Okay. Okay. Good evening, my consultants, teachers, and colleagues. I'm Dr. Denaka. Today, I'll be taking questions 36 to 40, and I'll start with question 36. Question 36 says, which of the following statements regarding nuclear imaging and acute myocardial infarction is true? A. The size of the resting myocardial perfusion defect after acute myocardial infarction does not correlate with the patient's prognosis. B. Increased lung uptake of radioisotope at rest correlates with an unfavorable prognosis. C. Submaximal exercise imaging soon after MI is a better predictor of late complications than adenosine myocardial perfusion imaging. Then D. Technetium 99M Sesame B imaging is inaccurate in assessing the effectiveness of perfusion therapy. Okay, well, before we answer the question, I just want to give a brief information about the whole question. First of all, nuclear imaging is one of the tools that is used to assess acute myocardial infarction. What it does is that it provides information about the size of an infarct. It also helps to check about the function of the heart and also the metabolic activity of the heart. Now, this myocardial perfusion imaging is also known as a nuclear stress test. What it does is that it uses a very tiny amount of a radioactive substance, which we call a radioactive tracer. Now, this tracer will now travel through the bloodstream and also get through the muscles. And when it goes through the muscles, these muscles absorb this radioactive element. And some of the radioactive elements are actually either thallium-201 or technetium-99. These are the two common ones that are being used in this myocardial perfusion imaging, also known as nuclear stress test. And what happens is that when this radioactive substance goes through the heart muscles, it's been absorbed by the normal areas, such a way that the damaged areas or the areas that don't have a good blood flow do not absorb this tracer. So what happens, it is the normal areas of the myocardium, the ones that have a good perfusion, that absorb this radioactive substance. So it helps you to see the abnormal areas. Now, what you have noted that when these are absorbed, the size of this defect actually correlates with the prognosis. So what it means that when there's an absorption and there is a larger defect, it means that there's a patient has a worse prognosis. So the larger the size of this defect, the worse the prognosis. So that's one thing we need to know. Now, another thing we also need to know is that when there is this resting imaging, when it's actually done in a resting stage, the patterns shown after a myocardial infarction is such a way that there's an increased lung uptake of these radioisotopes. So what happens is that it shows an unfavorable prognosis because they actually indicate impaired left ventricular function. So that's just a brief summary of what we need to know about this myocardial perfusion nuclear imaging. So going back to the question, it says the size of the resting myocardial perfusion defect after the myocardial infarction does not correlate with the patient's prognosis. That is not actually true. The size actually correlates. Now, the increased lung uptake of this isotope correlates with an unfavorable prognosis. So that is the answer, because like I said, the resting image actually, when after this MI, when there's an increased lung uptake, it actually is associated with unfavorable prognosis. So the answer to this question 36 is B, which says increased lung uptake of radioisotope at rest correlates with an unfavorable prognosis. So that's the answer to this question from what I just explained now. Meanwhile, these answers A, C, and D are incorrect. So the correct answer to this question is option B. So I don't know if anybody has to say, should I go on?
Kindly go ahead if there's no contribution.
Okay. So for question 37, it says, a 61-year-old man presents for a treadmill exercise test because of intermittent chest pain. He believes he had a small heart attack in the past. He has a history of prior tobacco use, and his father died of a myocardial infarction at age 68 years. His baseline ECG shows normal sinus rhythm with pure waves in the inferior leads. At 6 minutes into the Bruce protocol, he develops mild anterior chest heaviness, and the ECG demonstrates ST elevation in leads 1, AVL, V5, and V6. Which of the following statements regarding ST segment elevation during exercise testing is correct? 1. Segment elevation during exercise testing is a common finding in patients with coronary artery disease. B. ST segment elevation in a lead that contains a pathologic pure wave at baseline indicates severe myocardial ischemia. C. The electrocardiographic leads that manifest ST segment elevation during exercise localize the anatomic regions of ischemia. D. ST segment elevation that develops during exercise is usually a manifestation of benign early repolarization, while E says ST segment elevation during exercise is commonly associated with development of complete heart block. Okay, having looked at this question, it's talking about stress tests. And from what we've known, we know that exercise stress test is also, we also call it treadmill test. And what this treadmill test does is that it measures how the heart works during a physical activity. And one of the indications for this treadmill test is it helps to diagnose heart conditions of patients such as patients who have coronary artery disease. And we know that this treadmill test, well, most time when they do it, we have low risk, intermediate risk, and high risk. But for most patients who undergo this exercise test, are patients who are actually in the intermediate risk level. Now, it's worthy to know that this treadmill test is done using the Bruce protocol, where the patient is actually placed on a machine. And one of the things we check for are the patient's heart rates, the blood pressure, and the ECG changes. Those are the things we actually record. And it's worthy to know that before in this treadmill test, it's good to know this patient's pre-test ECG level and also the patient's pre-test vitals before the patient actually starts undergoing this treadmill test. And when the patient is doing this treadmill test, there are positive tests. When it's said to be positive, there are factors when you see them, you know, these patients have a positive test. And one of the things you actually notice is if a patient has a horizontal or down sloping ST segment depression of at least 1 millimeter, it's one of the signs of a positive test. And also if a patient has an ST segment elevation of more than 1 millimeter, also if patient also has a frequent preventricular contraction, PVCs, then also it can also be said to be positive when the patient has an exercise-induced right or left bundle branch curve with associated angina pains. These are the things that when you see it on ECG, you start noticing that this is a positive result. Now, it's worthy to know that when this ST segment develops during exercise, it is actually a predictive value. It shows the presence of a transmural ischemia. So if you are doing this treadmill test and the patient and you look at ECG, is showing an ST segment elevation, it's actually predictive presence of a transmural ischemia. Then also, development of this ST segment elevation is also useful to localize anatomic sites of an ischemia. And this typically correlates with a perfusion defect on an imaging study. So if a patient is doing this and you find out this patient has an ST segment elevation, that point at which that ST segment occurs is actually, it helps to localize the anatomic site. And this is actually said to be typically correlating with, if you do a perfusion testing, a perfusion imaging, it actually correlates with the defect on when you do an imaging studies. Now, it's worth to know that patients who have early repolarization is a normal response to a J point. And what's happening if the patient has any repolarization and this J point later returns to baseline during exercise, it is a normal finding. Then also, an ST segment elevation during exercise does not have a predictive significance when it comes to leads that contain a pathologic cure wave. So if a patient already has a pathologic cure wave before this exercise testing, and while this patient is undergoing this treadmill test, starts developing an ST segment elevation in that particular lead, that particular lead that already has that pathologic cure wave, it does not have a significance. So that's what we need to know. Now, going back to the question they asked, looking at the question, and it says, A, ST segment elevation during exercise test is a common finding in patient with coronary arteries. Of course, this is a false answer. It's not true, because we are looking for the true answer. Then ST segment elevation in a lead that contains a pathologic cure with at baseline indicates severe, because I already explained that this patient with you don't. Hello, can you hear me? Hello?
We can hear you, sir.
Okay. So, like I already said, so when there's an ST segment elevation in a lead that already contains a pathological weight, it does not indicate a myocardial ischemia, because the patient already has an old injury. So looking at it, then number 6 says the electrocardiographic ECG leads that manifest ST segment elevation during exercise localize the anatomic regions of ischemia. This is the true answer, because when I was explaining, I made a mention of that when there's an ST segment elevation during exercise, it actually localizes the anatomic region where the ischemia occurs. So going through the questions, the correct answer is C. So I don't know if anybody has anything to say, or should I continue?
Hi, good evening.
Yeah, hello.
Yes, so I just wanted to comment on a few things. So I agree with the correct answer being the C. When you were explaining, you mentioned the criteria for diagnosing a positive stress ECG. But one important thing to note is that as part of the normal response to exercise, the J point depresses. So then when you are reading the ST segments to determine whether it is positive or a negative stress test, what you do is you look at 60 to 80 milliseconds after the J point to detect. That is where you take your ST reading. So
Okay.
some text will say 60 milliseconds, some will say 80 milliseconds. So it's not the mere presence of an ST change, but it's an ST change at J point plus 60 or 80. The other thing was that you mentioned that frequent ectopic beats are diagnosis of a positive stress test, but that is so a VT during exercise. We usually term it as suggestive of coronary artery disease, not diagnostic. For PVCs, they may occur especially because of the increased adrenergic stimulation associated with exercise. So VT, yes, but for PVC, it's not exactly diagnostic. And so that's what I wanted to add. Thank you.
Just to also add, please, that PVCs can occur during exercise. What is our attention, or what draws our attention, are usually PVCs seen during the recovery phase. When you see PVCs that persist from exercise and then you see them during the recovery phase, they usually have poor prognostic factor or adverse prognostic significance, but that does not necessarily mean that it means a positive test. Thank you.
Okay. Thank you so much, sir.
And I think just as reinforcement, so we should have done these questions earlier, but subsequently we answered the question where the 60 to 80 milliseconds from the J point, as some might remember, was part of the possible answers in one of the questions.
All right.
So it's important to note that 60 to 80 milliseconds. Thank you.
Okay. Thank you so much, sir.
Good evening.
Good evening.
Thank you, the presenter. Mine is more of a clarification on the option B. Is it that when there is ST segment elevation, in the presence of the Q wave, the pre-existing Q wave, that ST segment elevation is negligible. You just treat away. Or it means that there's no additive effect. That's what
Okay,
I just want to clarify.
Okay, when I read, they actually say because that's an old info, it's not really predictive. That's what they use. They said it's not really predictive. So I didn't really dwell further to know, but because patient already has an pathological cure, as an old this is more of an old ischemic injury. So and now this is a new one. It's it's not really predictive. That's what I understand by what they said.
Okay, thank you very much.
Okay. So should I go to 38? Okay, thank you. Question 38 says, which of the following statements regarding coronary calcium assessment by electron beam tomography is true? The amount of calcium on electron beam tomography strongly correlates with the severity of coronary disease detected by angiography. B, patients who benefit most from screening with electron beam tomography are those at a high risk for coronary events based on traditional risk factors. C, the absence of coronary calcium completely excludes the presence of severe obstructive coronary. E, a coronary calcium score higher than the median confers an increased risk of myocardial infarction and death. So this question is talking about electron beam tomography. And it's worthy to know that electron beam tomography is actually a non-invasive method of detecting coronary artery calcification. Now, it is also increasingly being advocated currently. This coronary electron beam tomography is being advocated as a diagnostic test for coronary artery disease. So it's actually a non-invasive method currently that is being used to detect patients who have coronary artery calcification. Despite the fact that coronary artery calcification is a surrogate marker for coronary atherosclerotic spread, it has a weak correlation between the amount of coronary calcium and an angiographic severity of the coronary artery disease. So if in as much as it's being used, but the coronary calcification is in as much as it's a surrogate for atherosclerotic spread, it has a weak correlation. That's what we need to know. And you also need to know that the complete absence of calcification on an electron beam tomography has a strong negative predictive value for high-grade coronary stenosis, but it does not completely rule out presence of significant coronary artery disease. So what it means that in as much as the patient has a complete absence of calcification, and when you do an electron beam tomography, it has a strong negative predictive. Hello? Hello? Can you hear me?
Yes, we
Hello?
can hear you. We can hear you.
Yeah. Okay. Because I just heard a noise, I thought, as I heard the voice, I thought it was okay. So now, like what I was saying, so like this electron beam tomography, like I said, is a non-invasive method. It's one of the non-invasive methods which is currently used now to check for coronary artery calcification. And even if there is an absence of this calcification and EBT, it is said to have a strong negative predictive value for patients who have high-grade coronary stenosis, but it does not completely rule out that this patient has significant coronary. So what is it? Despite there's an absence of this on EBT, does not necessarily mean that this patient does not have a coronary artery disease. And now there's a scoring system known as the Agatston scoring system. It's now being used frequently to report this severity of coronary artery calcification. And it also is used now to check for patients, to have patients who have this coronary artery disease. However, it's said that these patients, when you check them, it's being stratified for age and gender. So this Agassiz scoring system has a reference data that helps to interpret this patient's calcium score, and it's said to be stratified for age and gender. And it's of note that this coronary electron beam tomography is a very most clinical value for patients who have intermediate risk for coronary events that is based on traditional cardiovascular risk factors. So if a patient has a cardiovascular risk factor, it's been shown that this coronary electron beam tomography is actually a clinical value to look at screen patients who have intermediate risk of coronary events. So having summarized this and going back to the question which talked about electron beam tomography, they said which one is true in coronary calcium calcification. They said the amount of calcium on EBT strongly correlates with severity of coronary disease detected by angiography. This is not true, which I already explained. B, patients who benefit from screening with EBT are at high risk for coronary events based on traditional risk factors. This is not true. Like I said, it's for patients who have intermediate risk. Then the absence of coronary calcium completely excludes the presence of severe obstructive coronary artery disease. This is not true, like I already explained. And interpretation of calcium score is independent of patient's age and gender. This is not true. Like I said, the interpretation is stratified by age and gender from what I explained. Why it says a coronary calcium score higher than the median confers an increased risk of myocardial infarction and death. So if looking at these questions and the question and the answers, the most correct answer currently is E. So that's why I went for E. So the answer I chose is E. And I don't know if anybody has anything to contribute.
So what I want to add is your, like you rightly mentioned, is a test that helps in risk stratification essentially, and can be a risk modifier, but it can be influenced by statins. So patients on statins or who have been on statins for a relatively longer duration can have an elevated accident score that may give you the perception that they have a relatively increased risk of coronary artery disease. So we should always also have them at the back of our mind that statins can influence the interpretation of coronary artery calcium score.
Oh, thank you so much, sir. Yeah. So question 39. Can I go to question 39, please? I'm not seeing it on my screen. Okay, thank you. No, I think you just moved it further up. Okay, thank you so much. I can see it now. Now, question 39 says, which of the following statements is true regarding prognosis as determined by myocardial perfusion imaging? A, patients with normal perfusion in the presence of angiographically documented coronary artery disease have very low rates of cardiac events of, in bracket, less than 1% per year. B, thallium imaging results in less breast attenuation artifact compared with technetium 99M sestamidine. 3, transient ischemic dilatation of the left ventricle and long uptake of the nuclear tracer are common findings in normal individuals. D, the combination of clinical and cardiac catheterization data is more predictive of subsequent cardiac events than the combination of clinical and myocardial perfusion data. Then E, the risk of future cardiac events is unrelated to the number or extent of myocardial perfusion defects. Like, I think in question 36, we discussed about nuclear imaging, which myocardial perfusion imaging was what we talked about. So, and this question also is still talking about myocardial perfusion imaging. And another thing one of the things we need to know is this myocardial perfusion imaging, which we already said, provides an important source of information in patients with coronary artery disease. Now, this stress myocardial perfusion imaging also has been shown to be a powerful predictor of subsequent cardiac events. So it also predicts a subsequent cardiac events for patients who has coronary artery disease. Now, we need to also need that the combination of a clinical and myocardial perfusion data is more predictive than the combination of catheterization data and clinical data. So one thing we want to know that for this myocardial perfusion imaging, say that when there's a combination of a clinical and myocardial perfusion data, it has a more predictive value than when you combine catheterization and clinical data. And also one thing also we need to know is that if coronary artery disease is present, a normal myocardial perfusion study confers a very low risk of cardiovascular events. So whenever there's a coronary artery disease present in the patient and you do this myocardial perfusion injury imaging, it has a very low risk of cardiovascular events. And also this stress perfusion defects in multiple locations corresponds to multiple vascular territories, which are suggestive of left main or the patient. It also confirms to know whether the patient has a left main or three vessel disease, coronary artery disease, because coronary artery talks about vessels. And also there are other indicators of high risk coronary artery disease, which include patients who have a large defect, if the patient has a transient pulmonary uptake of tracer, and if also patient has a left ventricular cavity dilatation with exercise. So if the patient has a left ventricular cavity dilatation with exercise, is a high risk of coronary is an indicator of high risk coronary artery disease. And if patient has a large defect on perfusion, and also this patient, if they have a transient pulmonary uptake, these are indicators of high risk coronary artery disease. Now, also we need to know that severity of myocardial perfusion defects can be assessed in terms of both the size and extent of its reversibility. Another thing we need to know is the predictive value of this myocardial perfusion imaging is independent of the imaging technique and imaging agent used. So no matter the imaging technique you use, the myocardial perfusion injury is imaging is independent of any technique or imaging you use. But another thing we need to know that the severity of these defects, as well as the number and the size, they are important indicators of prognosis. So if the larger the defect, then what's the prognosis? Like we already had said in question 36. So going back to the question and the answers, the answer says patients with normal perfusion injury, patients with normal perfusion in the presence of angiographically documented coronary artery disease have a very low rate of cardiac events. So from what I explained, I said even if there's a cardiac, if patient has a coronary artery disease and also has a normal perfusion study, a normal perfusion study confers a very low risk of cardiovascular events. So if you look at these questions and the options given, the most correct answer here is option A, which says that patients with normal perfusion in the presence of angiographically documented coronary artery disease have very low rates of cardiac events, and it was said to be less than 1% per year. So the correct answer here is option A.
Hi again. So I just want to just highlighting the answer A, just to draw our attention to the fact that the presence of a coronary artery lesion anatomically in itself does not necessarily confer a poor prognosis, and so it depends on the physiological importance of the lesion. So angiographically, you can do things like the FFR and the IFR. That tells you what the flow distal to the lesion is, and then that has a stronger bearing on prognosis. So it's similar to this situation where you have a lesion, but on the myocardial perfusion imaging, there's adequate perfusion despite that lesion. So even if, for example, it's a 70% lesion with good perfusion, and you have another person who has a 50% lesion with poor perfusion, that 50% with a 50% lesion has a worse prognosis because that occlusion or that lesion is more hemodynamically or more physiologically significant. Thank you.
Thank you, sir. Question 40, sir. Okay, question 40. It says, a previously healthy 28-year-old man presented to the hospital because of 1 month history of progressive exertional dyspnea, weakness, and weight loss. One day before hospitalization, he was unable to climb 1 flight of stairs because of shortness of breath. On examination, he appears fatigued with mild respiratory distress. His blood pressure is 110/70 millimeter mercury with pulsus paradoxus. His heart rate is 110 beats per minute and regular. The jugular veins are distended with Cosmos sign. Pulmonary auscultation reveals scant basilar rails. The heart sounds are distant. There is mild bilateral ankle edema. As part of the evaluation, he undergoes cardiac magnetic resonance imaging. A short axis view at the mid-ventricular level is shown in figure 1.8. Which of the following is the most likely diagnosis? A. Pericardial malignancy. B. Chronic organized pericardial hematoma. C. Constrictive pericarditis. D. Extratumor compression of the heart. E. Congenital patient absence of the pericardium with cardiac herniation. Okay, when I was going through this question, I had to go look at the image they put there. And to be honest, the image is a cardiac magnetic resonance imaging. And what I tried to do was I was trying to match that imaging to the best, to what fits most. So when I had to put cardiac magnetic resonance imaging of the options given, I found out that the closest one to that imaging was actually option A, which said pericardial malignancy. But honestly, I didn't really know the reason because I couldn't. That was what I could find when I actually tried to match those the image with the options. So I had to put pericardial malignancy and all those images, all those. I had to put them online to know the imaging. So the best I saw was that. So that was why I went for the option A. So I don't know if anybody can help me out or if there's any other options or possibly there's a counter option to that. But from what I saw in the net, that particular imaging was what really suits pericardial malignancy. So that was why I went for option A. And thank you. Hello.
Yeah, hello.
Yeah.
Yeah, so I think our presenter is asking also for contributions for this question. Any contributions?
Eugene, can you please show the image? Okay, so when I look at it, see that within the ventricular cavities is hypo-intense. So for me, I assumed that fluid in this, I'm not sure whether it's T1 or T2 weighted, but I assume that fluid will be hypo-intense. So I thought it was pericarditis even one of the answers. Please scroll up again. Okay, okay, so I didn't I would have expected that it was a constrictive pericarditis because of calcification of the pericardium, it would be right, which was not there in that case. So I didn't think it was a constrictive pericarditis. Definitely I thought it was something within the pericardium. So then I took D out. And since I thought there was a pericardium, that means E was out. So for me, it was between A and B. I'm not sure if, and I know when a hematoma organizes, it can look like a mass, but I couldn't really um, justify differentiating between an organized hematoma and pericardial malignancy. The others I was okay ruling out, but for A and B, I couldn't objectively tell the difference between the two of them.
So thank you, sir. And that's the end of my numbers.
Okay, thank you very much. Just a question. Considering the fact that the patient has this patient has a pericardial malignancy, what is the likely explanation why this patient did not exhibit pulsus paradoxus and or Kussmaul sign? Looking at the scenario and the imaging, is there a possible explanation?
Oh, honestly, I thank you for the question, Dr. Eugene. I actually was thinking that, but to be frank, I thought about that, but I couldn't really come up with an answer. So that's why I don't know if anybody can help me, just in honesty.
I'm not certain, but I think considering the fact that it appears localized and probably does not involve the entire pericardium or the entire pericardial space. And so probably that may be the reason why it did not exhibit the positive Kussmaul sign or the pulsus paradoxus. That is just my thinking. I'm not certain.
I think I don't think you're out from that, but I think it could be. But honestly, I didn't really more of like think about that in honesty.
It looks like how many days that. And I also didn't think that the mass was compressing on the ventricle such that it was affecting ventricular and pressure and ventricular filling significantly. So I thought that was why there was neither pulse paradoxus in this small form.
Oh, okay. That's also reasonable. Thank you. So we move to the questions 66 to 70. I don't know whether our colleague is on, Dr. Ayodeji. If it's not on, I saw Dr. Asori on. So Dr. Asori, you can take 76 to 80 if you are on, please. Is Dr. Asori on?
Okay. Good evening, I'm around. Good evening.
Good evening, sir.
Thank you. So thank you and good evening, consultants and our colleagues here present. So I'll be taking number 76 through 80.
You can go ahead if you see the screen, please.
Okay, thank you. So number 76. Hope I'm audible, please.
Yes, you are.
Okay. Which of the following statements regarding pulsus alternans in patients with marked left ventricular dysfunction is true? A. It is usually associated with electrical alternans of the QRS complex. B. It is less readily detected in the femoral artery compared with the radial artery. C. It cannot be detected by non-invasive sphygmomanometry. D. It can be enhanced by the assumption of erect posture. While E. It is uncommon for patients with pulsus alternans, or it is uncommon for patients with pulsus alternans also to have an S3 gallop. As discussed yesterday and the previous day, I think we talked about some of the characteristics of some pulses, including pulsus paradoxus. So now it's time for alternans. I'll just take each of the questions, each of the options, and just give the answers to them. So for option A, an overview, let me just start with a little overview on pulses alternance. As we know, there are actually beat-to-beat variability of the pulse amplitude, and it's almost always indicative of left ventricular systolic dysfunction and usually carries poor prognosis when we actually elicit it. For the A option, we said it is usually associated with electrical alternance of the QRS complex. It is actually more associated with T-wave alternance. So let's note that it's more associated with T-wave alternance. And when that happens, it poses arrhythmic risk. In QRS complex alternance is more with pericardial effusion rather than pulsus alternance. So the number A option is false because of that QRS complex in relation to T-wave alternance rather. Then for option B, it is less readily detected in the femoral compared with the radial arteries. Rather, it is easily detected in the femoral than other arteries. You can also use other arteries. You can also detect it in both the brachial and the radial artery, but it is said to be easily detectable in the femoral than other arteries. So that makes option B false. Then for option C, it cannot be detected by non-invasive sphygmomanometry. This option is also false because while detecting pulsus alternance, actually pulsus alternance, it comes on from marked left ventricular dysfunction. So when there's a marked left ventricular dysfunction, we expect that the ejection fraction of that patient will be low, hence the stroke volume will be low. Then with time, because of the increased pressure in the left ventricular chamber from the reduced stroke volume, there will be myocardial stretch. And because of the Frank-Starling principle that we all know, with time, there will be a marked push of blood, or there will be a more forceful stroke volume. So that is why we talk about the variability. So actually, the best way to check for or to confirm pulsus alternance is through the normal way we check blood pressure. So when we check blood pressure with the normal cuff, we usually increase the cuff to elevate more than this normal systolic pressure. And then you slowly lower it. Then when you hear this alternating loud and soft cold cough sound, this confirms pulsus alternance. So that makes this C option a false option because it said non-invasive. So you do not really need an intra-arterial sphygmomanometer to confirm pulsus alternance. The normal basic one we use can confirm that. D option, it can be enhanced by the assumption of an erect posture. This is the true option because pulsus alternance can be enhanced by maneuvers that maneuvers that reduce venous return, like standing from squatting position and Valsalva. These maneuvers actually enhance or exaggerate pulsus alternance. So that's the true option. Option D is the true option. While option D, it is uncommon for patients with pulsus alternance to also have an S3. As we say, pulsus alternance is common in patients with heart failure, left ventricular dysfunction. So we expect S3 in such patients. So that is a false option. So answer to number 73 is D. Any contribution or clarification? So if none, I will move to 77. Which of the following statements regarding exercise testing is true? A, frequent ventricular ectopics in the early post-exercise phase predict a worse long-term prognosis than ectopics that occur only during exercise. B, patients who develop QT interval prolongation during exercise testing are good candidates for class 1A antiarrhythmic drugs. C, the appearance of sustained supraventricular tachycardia during exercise testing is diagnostic of underlying myocardial ischemia. D, exercise-induced left bundle branch block is not predictive of subsequent cardiac morbidity and mortality. E, tachyarrhythmias are commonly precipitated during exercise testing in patients with Wolff-Parkinson-White syndrome. Exercise testing, Dr. Denaka just presented, talked about exercise testing, so I may not go much about it. Some of the options here will also discuss them. So if I start with the first option, A, ventricular ectopics. As we know, ventricular ectopics, one of us contributed to that discuss earlier, that ventricular ectopics can be normal. In fact, it is said to occur in about 20% of patients during exercise testing, which can vary from isolated PVCs to non-sustained VTs. Although when frequent ventricular ectopics occur during exercise or the recovery phase, hello, am I audible, please? I think I lost my network just now. Hello?
Yeah, you went off briefly, but you're audible.
Okay, thank you. Okay, I said frequent ventricular ectopics, they can occur during, when they occur during exercise or even the recovery phase, it's said to be significant. And this occur, as our colleague said earlier, this usually occur, especially during the recovery phase or post-exercise phase, because of circulating catecholamines, which continue to increase for several minutes after the exercise. So for the A option, it is a true statement because of what I just said. And ventricular ectopics can usually occur post-recovery or post-exercise because of the circulating catecholamines. But what my confusion is in this question is that you said frequent ectopics in the early post-exercise phase predict worse long-term prognosis than ectopics that occur only during exercise. Because from what I saw from readings, I saw that for symptomatic populations, ventricular ectopics during exercise or during the recovery phase is predictive of mortality and increases the likelihood of future cardiac deaths, especially if the patient have a right bundle branch block morphology as opposed to left bundle branch morphology. So in the statement in Braunwald'S, they clubbed the two together. Said when it occurs during exercise or post-recovery, it predicts worse prognosis. But in this question, they said when it occurs in the early post-recovery phase, it portrays worse long-term prognosis than ectopics that occur only in exercise. So it is like a separation from both of them. But the answer from Braunwald'S is A. For the B option, patients who develop QT interval prolongation during exercise testing are good candidates for class 1A antiarrhythmics. Well, exercise testing are also useful to assess response and the risk of antiarrhythmics drug therapy. Hence, prolongation of QT during exercise identifies patients at risk of pro-arrhythmic drugs on class 1A. On class 1A drugs. So that makes this option a false statement because they said patients who develop QT interval prolongation during exercise testing are good candidates for class 1A. But actually, patients who develop prolongation of QT interval during exercise on these drugs, it portrays risks for pro-arrhythmic effects of the class 1A drugs. So that makes this question B a false statement. Then going further, why QRS during exercise also, if the QRS complex widens on a patient on class 1C drugs, that predicts the pro-arrhythmic effect also. So on exercise testing, it's not just about class 1A and class 1C, class 1A drugs, even class 1C drugs. So for us to remember, prolongation of QT interval with type 1A drug puts them at risk of the pro-arrhythmic effect, while widening of QRS complex on class 1C drug predicts the pro-arrhythmic effect of these drugs also. So this makes question B false statement. So for question C, the appearance of sustained supraventricular tachycardia during exercise testing is diagnostic of underlying myocardial infarction. That is a false statement because exercise-induced SVT are not predictive of ischemia or any cardiovascular endpoint. Rather, they are marker of later occurrence of atrial fibrillation or SVT. So that makes it a false statement. For the D option, exercise-induced left bundle branch block is not predictive of subsequent cardiac morbidity and mortality. Of note, during exercise, there is normally shortening of QRS complex, PR interval, and the QT interval. Then exercise-induced bundle branch block can occur in some rare instances. They said from Braunwald'S about 0.5%. Exercise-induced bundle branch block can occur. But normally, what happens is shortening of QRS interval, shortening of PR interval, and also the QT interval. There are different studies that were carried on patients with left bundle branch block, exercise-induced left bundle branch block. And one of the association, there was association of exercise-induced left bundle branch block with deaths and major cardiovascular events. While another study suggests that when exercise-induced left bundle branch block occurs with heart rate greater than 125, cardiovascular events are unlikely. But it is likely when the heart rate progressively reduces. So those are the two studies that were carried out in patients that develops exercise-induced left bundle branch block. One of the events, if a patient develops exercise-induced left bundle branch block, it is a major, it carries increased deaths and major cardiac events, while also another study correlates it with heart rates. So that making that option, D option, also a false option. Then for the E option, tachyarrhythmias are commonly precipitated during exercise testing in patients with Wolff-Parkinson-White syndrome. As we know, Wolff-Parkinson-White is a pre-excitation syndrome that arises from abnormal cardiac electrical conduction through an accessory pathway. As a way of reminder, the hallmark of Wolff-Parkinson-White is wide QRS complex, short PR interval, and a delta wave formation. But exercise-induced tachyarrhythmias rarely occur in Wolff-Parkinson-White because the effect of catecholamine still come in here in this situation. Those catecholamine release, they usually favor the antegrade conduction through the AV node. As you know, Wolff-Parkinson-White has two pathways, can have two pathways, the normal pathway and also the accessory pathway. So for exercise-induced arrhythmias, it rarely occurs because during exercise, there's catecholamine drive, which makes the conduction favor the normal routes, goes through the AV node, the East Purkinje to the ventricles, then depolarizes the ventricles. So in this manner, they display the normal QRS complex, normal PR interval, and disappearance of delta waves. So that makes that option the first option because it said tachyarrhythmias are common, but rather it is not common because of the release of catecholamines. Any question, please, or clarification to 77? Option to 77, correct option is A.
Well, please, I have a clarification.
Okay.
Please, when you are talking about the increased QT interval, that it's make them to have increased position to poor arrhythmias, but you said the widened KRS complex make them to be. I didn't get that second part. When we are comparing
in the Wolff-Parkinson-White.
No. The option B.
Okay.
When you are explaining QTC and the widened KRS complex, the effect on arrhythmias.
On the different drugs.
Yes.
And they are in relation to the effect of different drugs. On exercise testing, patients with antiarrhythmic drugs, if they are on class 1A drugs, prolongation of QT interval can enhance the pro-arrhythmic effect of class 1A drugs. While patients on class 1C drugs, there could be widening. When there's widening of QRS, there will be widening of QRS complex during exercise. That will also potentiate the pro-arrhythmic effect of class 1C drugs. So QT interval is with class 1A drugs, while QRS interval widening is with class 1C drugs.
Thank you.
Do you understand, please?
Thank you, yes.
Okay, thank you. Should I go ahead or further clarification on some of the questions? Okay, 78. Which of the following statements regarding extrasystolic sound is true? A, ejection sounds are high-frequency clicks that occur in mid to late systole. B, the ejection sound associated with pulmonic stenosis decreases in intensity during inspiration. C, aortic ejection sounds they vary with respiration, occurring later in systole during inspiration. The D option, the bedside maneuver of standing from a squatting position causes quick of mitral valve prolapse to occur later in systole. So, a little overview of the systolic sounds. Systolic sounds are otherwise known as ejection sounds. And there are other ejection sounds are two types, which is the systolic sound and the diastolic sounds. But in this question, the emphasis is on the systolic rather than diastolic sounds. Ejection systolic, if we take the A option, for example, let me go option by option. And for the A option, ejection sounds are high-frequency clicks that occur in mid to late diastole. Rather, ejection sounds are actually high-pitched and they occur early in systole. As relation to this question here, they said mid to late. It occurs early in systole, and they actually coincide with the upstroke of carotid pulse. Unlike diastolic sounds, they coincide with when the upstroke, with the downward trend of the carotid pulse, unlike systolic that coincide with the upstroke of the carotid pulse. So that making this option a false option. For the B option, ejection sound associated with pulmonic stenosis decreases in intensity during respiration. This is a funny question because this is a funny option, but it's the true option. We all know that, there's this physiology, or there's this popular physiology that right-sided sounds or right-sided murmurs, they increase in intensity during inspiration, while the left-sided, they increase during expiration. But pulmonic valve disease, they actually defy these arrangements. Hence, they decrease in intensity in inspiration. So that's normal physiology that we know, that normal code. There's this code, right-sided valve or right-sided murmurs, they increase in inspiration. But for the pulmonic rather decreases in intensity during inspiration. This making this option a true option. So this is not a false option, it's a true option. Then for the C option, aortic ejection sounds, they vary with respiration, occurring later in systole during inspiration. Actually, ejection sounds, as I said earlier, they can either be their systolic sound, which can be either aortic or pulmonic in nature, and they usually occur early in systole. This option now is saying they occur later in systole. They actually occur early in systole. And for aortic ejection sound in particular, they do not vary with respiration. So there are two caveats here making this option a false statement. One, aortic ejection sounds, they occur earlier in systole and they do not vary with respiration. So this making C option a false option. For the D option, the bedside maneuver of standing from a squatting position causes the click of mitral valve prolapse to occur later in systole. Well, systolic clicks in mitral valve disease, are actually non-ejection clicks, unlike the others we'll be talking about that are ejection clicks. For mitral valve prolapse, they are usually a non-ejection click, which occur after upstroke of the carotid pulse. Standing actually decreases ventricular preload and afterload. Hence, the click or murmur moves closer to S1, making it occurring early in systole. So the part of this D option that is making it the first statement, they said it occur later in systole, but rather it occurs early in systole in standing position or Valsalva because of the reduced ventricular preload and afterload. Unlike the other way around, if it is in squatting position or anything that increases preload or afterload, it can now occur later. So we should, in this particular D option, we should take note of standing, if it's standing or squatting position, which increases or reduces preload. If it's standing, as this question says, it reduces preload and afterload and makes it occur closer to S1, making it early in systole. Unlike squatting position, which increases afterload or increases preload, it makes it further from systole, that is later in systole. So the option to 78 is, the answer to 78 is B.
So just for clarification, the member of right-sided murmurs, with this one, is it increased because of this pulmonic stenosis, or just for that applies to all pulmonic murmurs? Because we know that right-sided murmurs. Yeah.
That question actually came to my mind. And when I read about the physiology, why that happens is because in right-sided murmur during inspiration, in the right-sided physiology during inspiration as well, there's increased venous return. And when that pool of blood enters the right atrium, that pool of blood entering the right atrium, of course, makes the tricuspid close. But at the same time, because of the gush of volume of blood that enters, the pulmonary valve opens a little bit. During expiration, that is when the pulmonic valve now opens with force. That is why it's exaggerated during expiration rather than inspiration. So I tried to look deeper if it occurs during pulmonic stenosis or regurgitation. What I saw everywhere was just pulmonic disease. They just use the term pulmonic disease. So I can't really localize if it is a stenosis or regurgitation. But the question is giving us stenosis. So I just held on to stenosis because of that.
Okay, thank you.
Thank you.
So I think also as addition, what happens in significant pulmonary stenosis is your right ventricles hypertrophy. So your right ventricle, so if you have in inspiration where there is increased venous return, like you said, because of the relatively increased right ventricular and diastolic pressures in patients with pulmonary stenosis, that increased volume in inspiration actually increases the pressure to open the valve, the pulmonary valves slightly before ejection. And by so doing, it also reduces the sound. So that explanation has also been given. That relatively non-compliant RV with that increase in venous return with inspiration causes the pressures in the RV to increase to open the pulmonary valve out to improve the flow, reducing the intensity of the murmur.
Yeah, thank you very much. Can I go ahead? 79.
Yes, please, 79.
Okay. Which of the following statements regarding ECG in chronic obstructive lung disease with secondary right ventricular hypertrophy is correct? A, the mean KRS complex is typically less than 15 degrees. B, the amplitude of the KRS complex is abnormally high in the precordial leads. C, Even mild right ventricular hypertrophy produces diagnostic electrocardiographic abnormalities. D. A deep S wave in V6 is typical. E. Precordial lead transition is typically rotated in a counterclockwise fashion, in bracket, early transition. Okay, if I take them, okay, I would like to just give a little overview on the diagnostic criteria of right ventricular hypertrophy. That will enable us to go around some of the questions here as highlighted. And the diagnostic criteria for right ventricular hypertrophy are: one, when there's right axis deviation of greater than 110, greater than or equal to 110. Two, when there's a dominant arrow wave in V1 greater than 7 millimeter, or ratio of arrow and arrow to S greater than 1. The third criteria, dominant S wave in V5 or V6, like when there's a dominant S wave in V1, in V5 or V6, or ratio arrow to S less than 1. Then also QRS duration less than 120 is also one of them. Then also a positive voltage in AVR. So these are some of the diagnostic criteria of right ventricular hypertrophy. So if I go to the first option, the first option, the main QRS axis is typically less than 15 degrees. One of the criteria I read, I said the right axis deviation is usually equal to or more than plus 110, making the A option a false option. For the B option, the amplitude of the QRS complex is abnormally high in the precordial lead. As we know, there is COPD and some of the other respiratory conditions. There's hyperinflation. There's hyperinflation of the chest wall, so that would naturally cause low amplitude QRS complex rather than high QRS complexes, making the B option a false option. For the C option, mild right ventricular hypertrophy produces diagnostic electrocardiographic abnormalities. For right ventricular hypertrophy to be evident on the ECG, actually, it must be very severe enough to overcome the opposing effects from the larger and more compliant left ventricular hypertrophy. That statement from Braunwald makes the option C a false option, because they said even mild right ventricular hypertrophy is diagnostic. But Braunwald stated categorically that for right ventricular hypertrophy to be evident on ECG, it must be very severe. But here they said mild, so making the C option a false option. The D option is a true option. Said a deep S wave in VIX is typical. One of the diagnostic criteria I read, I talked about the dominant S wave in V5 or V6 is typical. Classically greater than S wave, classically greater than 7 millimeter, or arrow to S ratio less than 1. So making the D option the true option. For the E option, it's a false option, but let me go through it. Precordial lead transition is typically rotated in the counterclockwise fashion. Actually, for COPD, it is usually in the clockwise rotational pattern, and the transition is usually delayed. It is actually delayed due to this clockwise rotation caused by hyperinflation and enlarged right ventricle. When we talk about precordial transition, it's actually the point where the arrow wave is greater than the S wave. In this condition, there may be complete absence of, in some situations, there may be complete absence of the arrow wave in V1 to V6. So this option E is a false option, because in COPD is actually clockwise and is delayed rather than the opposite that is here. So the correct answer to option number 79 is D. So any clarification to 79? These are ECG features, so they are kind of straightforward. If no if no clarification or question, I'll move to number 80. Number 80 has also been discussed a few days ago. So I'll read number 80 goes thus. Which of the following statements regarding shunt detection is true? A, when an anatomic shunt is present, arterial oxygen saturation normalizes with administration of 100% oxygen. B, method of shunt detection include oximetry, echocardiography, and magnetic resonance imaging, but not radionuclide imaging. C, among the sources of right atrial venous blood, the inferior vena cava has the lowest oxygen saturation. D, due to the low sensitivity of oximetry for shunt detection, most clinically evident left to right shunts cannot be detected using this method. E, the FLAM formula is used to estimate mixed venous oxygen content proximal to the left to right shunt at the right atrial level. So I'll take them one after the other, then do some explanation to arrive at the correct answer. So for question A, they talked about anatomical shunts. So an anatomical shunts are actually defects, while they also have physiologic shunts. Physiologic shunts are abnormal passage that allow blood to actually flow between heart chambers, causing a low ventilation perfusion ratio. They usually occurs during conditions like cardiogenic shock, pulmonary edema, or in hypoventilation. If arterial desaturation persists after patient takes several breaths or after administration of 100% oxygen, an anatomical shunt is likely in this situation. Option A said, when an anatomical shunt is present, arterial oxygen saturation normalizes with administration of 100% oxygen. This is actually a false option, false question or option. It is a physiologic shunt that actually normalizes with administration of 100% oxygen or normal breath. For anatomic shunt, it doesn't. Because in anatomic shunt, it doesn't, because if it's something like a right to left shunt, for example, even with administration of oxygen, it doesn't normalize to 100%. For the B option, method of shunt detection include oximetry, echocardiography, and magnetic resonance imaging, but not radionuclide imaging. For detection of shunts, the commonest method used for determination of shunt actually in the cardiac catheterization lab is oximetry method. But other methods can be used, which include everything as mentioned there. So excluding radionuclide imaging is a false statement. So that made option B the false, because you can use both oximetry, echocardiography, magnetic resonance imaging, and radionuclide imaging. So that's a false option. For option C, among the sources of right atrial venous blood, the inferior venous cava has the lowest oxygen saturation. This has also been explained in one of the presentation earlier. The sources of right atrial venous pressure blood are usually from the IVC, SVC, and the coronary sinus. But oxygen saturation in IVC is higher than in the SVC and even the coronary sinus, because usually the kidney has a low oxygen extraction relative to other parts of the other organs like the brain and the heart itself, because the coronary sinus also drains directly into the right atrium, and it has a higher oxygen extraction in relation to the IVC. So this is the false option, which says from among the sources of the right atrial venous blood, the inferior vena cava has the lowest oxygen saturation. Rather, it has the highest oxygen saturation because the kidney has a low oxygen extraction. That is why it has the highest. So that's the first option. For the option, due to the low sensitivity of oximetry for shunt detection, most clinically relevant left to right shunts cannot be detected using this method. Actually, it can be detected using this method. So that is a false statement, because it can actually be detected, because obtaining multiple samples from the chamber still improves the sampling error, even in this situation. It improves sampling error and variability. For example, in suspected left to right shunt, if you want to sample, if you want to do oximetry sampling, you take from multiple sites. Take from multiple sites in the IVC, take from multiple sites in the SVC, take from multiple sites, the lower, middle, the higher part of the right atrium. Also take from the right ventricular inflow tract, outflow tract, mid cavity. You can take from the pulmonary artery and so on. All these will increase the sampling, will improve sampling error and variability. So even if the sensitivity of oximetry is low, it can still be used to detect shunts, to detect the shunts. For E option, the FLAM formula is used to estimate mixed venous oxygen content proximal to a left to right shunt at the right atrial level. This is the right statement because actually mixed venous oxygen content is actually the average oxygen content of blood in the chamber proximal to the shunt. So the formula used in getting this actually the FLAM formula. If we go through the text, you see that the FLAM formula, because as I said earlier, you take samples from multiple sites. So the FLAM formula is actually taking samples from the SVC, the oxygen content in the SVC from 3 different sites, and also oxygen content from the IVC, take from one side, divide by 4. So the average is used in calculating. So the FLAM formula is the perfect formula used in calculating or getting mixed venous oxygen content. So option E is the correct option. The others are false options. Any question?
Thank you very much. Please, if there are no questions, we'll continue to question 81. So question 81, Dr. Ike Joy Chineme, please, if you are on, can you take from 81 for us?
Okay, good evening, my teachers and colleagues. I don't know, but I'm so sorry. My mind was that I was to take 100 and something. I don't know why I thought it was 100 and something. Just now I saw that I'm supposed to take 81 to 85, but we can go through it. Yeche is here, Dr. Eugene is here. We can't go wrong, so we can go through it together.
Okay, you said you did question 100 and what?
I felt I was taking 100 and something. I don't know why. It's just now I saw your message concerning 81 to 85. So I think it was my own omission, but no problem. You're here, Dr. Eugene. We can go ahead. You would guide. So Yeche is here. We can't go wrong. So
Okay,
let me try rather than keeping us till
no
tomorrow.
problem. But
You
for
said
the,
it's
I just want to
question
find out
81.
whether Dr. Oji Miriam is on. If she's on, let's take hers, then we'll come back to your own.
Okay, I thought she's after me from
She's
what you
after
said.
you, yes. But I just want to find out whether she's on and she's done hers, so that we can let her take hers, then we come back to you. But if not, we can go through. So we have 81. Okay. All right.
Okay, so question 81. Which of the following condition is not often associated with a prominent R wave in electrocardiographic lead V1? So the A option says right ventricular hypertrophy. B says Wolff-Parkinson-White syndrome, Duchenne's muscle dystrophy, left anterior fascicular block, and misplacement of the chest lead. So for prominent R in V1, right, yes, if you have a type A, like if your left accessory part have R wave in V1, muscle dystrophy is also true. The statement of the test is true if you reversal like V3 and 4, you can have a increase in the R wave, and then if the cardiac or use the right hand lower on the left wall.
So Dr. I think your network is a bit poor. I don't know whether colleagues on the other end are hearing you, but the network seems to be quite poor.
We are not hearing her.
Okay, whilst we wait. Dr. Chineme.
And the network just came in. Yes, I can hear you now.
Okay, it's better now. Okay.
Okay, sorry, the network was fluctuating. So if you also put it lower down, the right-sided lead, you can have a prominent R in V1. Then I think it's also a normal variant in some children and young adults. Then you can also have it in patients with posterior myocardial infarction and HOCM, hypertrophic cardiomyopathy. You can also have it there too. So for this option, the wrong option is left anterior fascicular block. You don't have prominent V1 in left anterior fascicular block. Rather, the criteria for left anterior fascicular block is if you have a left axis deviation, then you have a QR pattern in in lead 1 and AVL, then you have an RS pattern in the inferior leads, and then the R wave peak time is more than 60 in AVL, I think. So those four would give you the left anterior fascicular block. So there's no criteria with an increased R in V1 for left anterior fascicular block. So I think that is the option that you won't have a prominent R wave in V1. I don't know if anybody has another answer or has a contribution.
I think I agree with you. But in addition, the left anterior fascicular block critically also counts the specific angle for the left axis, typically more than minus 45 degrees.
Yeah.
So not any left axis deviation, but the angle has to exceed minus 45.
Okay. Thank you.
And I think the peak to the R wave should be 40 milliseconds, I think in AVL, so I need to be certain. And the left anterior fascicular block has been associated with a positive voltage criteria for LVH, for the limb criteria, R wave in AVL, and also in Cornell voltage. So you may see a patient with left anterior fascicular block and will meet the criteria for R wave greater than 11 in AVL, but that does not necessarily mean there's left ventricular hypertrophy. It's because of the left anterior fascicular block. And they tend to also have deep S waves in the inferior leads too. So we can take note of that.
Okay. Thank you so much. Okay. I'll just, okay. The R wave peak time 45, greater than 45. Okay. All right. Thank you. So, question 82. The hemodynamic tracing illustrated in figure 1.19 is associated with which of the following features? So A, advanced valvular aortic stenosis. B, a bifid aortic pulse contour. C, normal left ventricular end diastolic pressure. I don't know what the other options are. I don't know if you can move up a bit. Is it to the side? No, it's not to the side. Dr. Eugene, please, can you go up a bit so that we can see option D and E? Thank you. So D, a delayed rise in the carotid artery pulsation. And then E, expected clinical improvement with transcatheter aortic valve replacement. Okay. So please, let's go to the pressure tracing. Okay. So looking at this pressure tracing, I hope I can remember. It looks like hokum, maybe because I've seen it a lot of time. But what I can remember clearly is that if you look, they are showing the left ventricular mid cavity pressure, which is in red, and then the aortic pressure. That's the pressure within the aorta, which is in blue. Now, if we're looking at the first three readings, let me call it readings, the first three spikes, you notice that the left ventricular mid cavity pressure is very high compared to the pressure within the aorta. And then if you now look at the last three, this should be when you're pulling the catheter out, you notice that the pressure becomes almost like equalizes. So if somebody has a valvular aortic stenosis, you expect that these last three, when you're pulling the catheter out, should be where the pressure will be very high because of the aortic stenosis compared to the left mid cavity pressure. But if you're looking at this one, you rather find out that the left mid cavity pressure is the one that is very high in the first two. That's when the catheter is within the mid cavity of the left ventricle. Then when you begin to pull out towards the aorta, the pressure drops. So that automatically rules out the fact that the patient has a valvular aortic stenosis. So this shows, that first three readings shows that the pressure is very high within the left ventricular mid cavity, and that should be in keeping with hokum. Then this other bifid, this bifid aortic tracing, there's a name they call it, but I've forgotten. This bifid aortic tracing, when it's seen, is in keeping with hokum. When you have this bifid aortic tracing, it's also in keeping with hokum. So if this is hokum, a bifid aortic pulse contour. Okay, the hemodynamic tracing is associated with which of the following features? A bifid aortic pulse contour, normal left ventricular end diastolic pressure. No, if it's hokum, of course, the end diastolic pressure will be very high. Then the D option says, okay, I can't see the D option again. Sorry, Dr. Eugene, can you go up a bit? Hello?
Dr. Chinim, I'm already there. I think there's a delay in the transmission because of the network. It will come.
Okay, sorry. A delayed rise in the carotid artery pulsation, that's also false from what I've explained. An expected clinical improvement with transcatheter aortic valve replacement. Hokum has nothing to do with transcatheter aortic valve replacement. This is if it was something with AS and all of that. So for this one, E is wrong, D is wrong. Then the best option, I can't even see the other options again. I think we've gone up. We need to go up. Okay. Then advanced valvular aortic stenosis, that's wrong. Normal left ventricular end diastolic pressure. If this is hokum, you can't have that. So I think the most appropriate answer to this question is option B, a bifid aortic pulse contour that is in keeping with hokum. Dr. Eugene, I hope it's not gone.
Yes, yes. Oh, no, I agree, I agree with you. I agree with you. So, like you rightly said, if you look at the ECG tracing, the peak of the R wave is consistent with end diastole. And if you look at it, your end diastolic pressure is about 20, which is high. So, like you rightly said, by the pathophysiology, you are not expecting the diastolic pressures in hokum to be normal. It will be elevated because the LV is non-compliant. So I agree with you. And clearly, you demonstrated and explained the increased pressure gradient in systole during mid cavity because we know that's what is happening. But this may not happen typically if you had an apical hokum because you can have different types of hypertrophy in different areas and they may not exhibit necessarily the mid cavity pattern. So yes, I agree with you. And if you look at the aortic waveform, it's normal throughout. So there is no evidence of valvular involvement on. So I agree with you. You were trying, the bifid is also known as the spike and dome, like you were trying to.
Okay.
So I agree with the answer as being
okay.
B. Yeah. So we can
Okay,
continue.
sir. Thank you. Please, do you have any other contribution? Okay.
Yeah, I think, let me see, there's something in the chat. Is this the broken brow sign? So there's a question from Charles Okori to the group.
Okay, he said, if this is what?
Is this the broken brow sign? Broken brow.
Brockenberg sign. I know that sign. I don't think it's this one, no, but I don't know. I know this one is that dome and spike. I don't think this is it too. I thought that Brockenberg sign is like a decrease in blood pressure after PVC. That thing has to do with PVC. I don't think this is it too. But I don't know, please. Anybody can help. But I think that broken bra has to do with PVC. It's not this. It's also seen in Hokum, but I don't know. I'm not too sure, sir. Let us check.
Oh, okay.
I'm not
So
too
I
sure.
think Dr. Okori will confirm that, but I think
you are correct. It's in relation to PVC.
Okay. But I know they also see it in Hokum somewhere, but I don't know.
Yes, it's in Okum. It's in
Okay.
Okum. It's in Okum, you see it, yes.
Okay.
Brockenburg, Braunwald'S, Moro Science, something. It's a very long name.
Cardiology, wahala is so much good. Okay, thank you, sir. Okay, so if but I'll still check it and maybe post later. Please, Dr. Okori, I'll check and post it, please. Okay, so question 83. A 53-year-old woman with a history of hypertension and obesity is diagnosed with triple negative estrogen receptor negative, progesterone receptor negative, HER2 negative left breast cancer. So she undergoes echocardiography that shows a left ventricular ejection fraction of 65% and average global longitudinal strain of 18.3%. She undergoes neoadjuvant therapy with paclitaxel and cisplatin. After surgery, she is treated with adriamycin and cyclophosphamide. She undergoes updated echocardiography 6 months after the first echo and prior to initiating therapy with trastuzumab. She shows an LV ejection fraction of 60%, okay, and GLS of 14.4%. She has no symptoms or sign of heart failure. Her heart rate is 50 beats per minute, and her blood pressure is 130/77. Renal and hepatic functions are normal. What will be the next appropriate step in management? Okay, I think for this one, we are just looking at the issue with anthracycline and the heart based on her chemotherapy. And what I know about this is that if somebody wants to have a chemotherapy done, they first of all have a baseline echo, which you can do by the normal transthoracic echo where you use the EF, or you can do via GLS. And then I know that if you have a drop in the EF, when the person, like you go and you have a baseline, you go and have the chemotherapy, you come back for a repeat. If you have a drop in the EF more than 10, I think drop by 10%. And then for GLS, I think it's 15. Hope I'm sure. It's in keeping with that, like the anthracycline is affecting the heart, and the patient should be off it for a while you do some form of cardioprotection. And I know the cardioprotection that is being used, we usually use ACIs, ARBs. You can also do beta blockers if there are no other contraindications for it. So for this for this woman now, her previous EF was 65%, and then the new EF was 60%, and the previous GLS, and the previous GLS was minus 18.3%, and a current GLS of minus 14.4%. She has no symptoms, no renal. They proceed with trastuzumab treatment plan. I don't think so. Post-treatment plan, repeat echo in 3 months. This is already 6 months down. Start carvedilol. She has bradycardia. I don't think carvedilol should be good enough. Then start lisinopril. So for this one, I think the better option should be to start lisinopril as compared to other ones, because carvedilol, she's already bradycardic. So to use carvedilol, not a good option now for her. So I just feel that should be a better option for her. Dr. Eugene, what do you think?
Oh, I think I agree with you, but if Dr. Ofosu is on, George, I will be happy if Dr. George Ofosu could throw more light in this area. He has an interest in this cardio-oncology. But whilst we are waiting for him to join, to talk, I saw his name on, but probably he's at work. But if he could contribute, I think he'll give us more information than I will. But I agree with the answer. I agree with you. Clearly, the patient has chemotherapy-related LV systolic dysfunction. And so the definition, the absolute reduction of more than 10% in baseline EF or reduction in the strain. There's been different definitions. That's why I wanted
for
the strain, the percentage reduction, whether 15 or 12%. I know they updated it, but I believe when he joins, he can clarify that for us. But both beta blockers and ACE inhibitors have been recommended. But I think in this case, the patient is bradycardic, and that is why the lisinopril will be the best answer to help improve the cardiac function. But in the absence of that, both beta blockers and ACE inhibitors have been shown in some studies that it helps with improvement in the LV function. So I don't know, Ofosu? Okay, maybe when he's able to come on, he'll give us more information. But I agree. Okay. I agree with you.
I think I need to hear that information.
It's something we're going to discuss. It's part of the guidelines. The guidelines we selected to discuss cardio-oncology. So it will come up definitely. Any contributions, please?
Okay. So we can go ahead.
Okay, 84.
Okay, so let's go ahead then. Then question 84. Golling's formula. This one I will never remember it too. Let me do 85 first. These things with formula, these Golling's things. I don't know if I can remember anything about it right now, but let me see question 85, please. I think that's the last question. If we can do that, then I can come back to that one. Okay. A 56-year-old man who underwent coronary artery bypass graft surgery 6 years ago has experienced exertional chest discomfort in recent months. He's not able to perform an exercise test because of chronic hip pain. So he undergoes an adenosine positron emission tomography vasodilator stress test, images from which are shown in figure 1.21. What is the correct interpretation of this study? Okay. So please, can we see the image? Okay. Let me see if I can go back. Okay, from the image. So this is like a PET. Shade the set positron emission, a PET scan. of the heart. So we know that most times if you want to stress the heart, you can either do exercise or you do pharmacologic methods, depending on if the patient has contraindication to the use of exercise stress testing. There are also contraindications to the use of pharmacological stress related agents also. So maybe this man, because of the chronic hip pain, he couldn't have an exercise stress done for him. So they chose to do like a pharmacological stress test with the use of adenosine, which is a coronary vasodilator. So it helps to show if there is an issue with the whole myocardium. So when you're looking at perfusion defects, from what I remember, it can be reversible or it can be fixed. So if you have a reversible defect, it's most likely that it's an ischemia. Then if you have a fixed defect, it's more likely to be an infarction or a scar. So how do you know if a defect is reversible is when you compare the stress and the rest images. So if during stress there's a perfusion defect, that means some area is not well perfused. There's a perfusion defect. And then during then it's a reversible defect. But if during stress, that perfusion defect is there, and then also during rest, that perfusion defect is still there, then it's a fixed defect. That means it can either be an infarction or it might be a scar at that area. So now looking at these images, the one that is the round image, I used to call it the round image, sorry, so that I can remember. So the round image has the up as the anterior, the down as the inferior, then your right hand is the lateral, and the left hand is the septal. Now, if you have this other one that is curved, it's usually anterior, inferior. So you can have the anterior part, the inferior part. Then there's another image that is curved up that used to have the base, the base, the anterior, the septal, and the lateral. So if you're looking at this image now, you can see that during the stress time, like looking at, I think that's 25 that is up, you can see some perfusion defects around the areas that we say is the anterior, and then this other septal side. Remember I said the one on the left is the septal. That side is the septal. So you can find out that there's a defect. That's a perfusion defect that is there during stress. And then if you now look at thank you, Dr. Eugene. If you now look at the side where you find the rest image, which is the part down, you can see that it comes back again full, like it gets perfused when the patient is at rest. So this invariably says that this is like a reversible defect, because when the patient is stressed, you can see the defect, and when the patient is at rest, it reperfuses itself. So it's more likely to be like an ischemia. The same thing goes for the lower image. You can see the stress zone, there's still a defect. And then if you look down, you can see during rest, it reperfuses itself. The same with all the images, stress and rest. So having understood that, we'll now go to answer the questions. Thank you, Dr. Eugene. Please, can we go to answer the questions? Okay. So they say question A. Okay, what's the correct interpretation of the study that we just looked at? So no perfusion defect. So of course that's false. We already saw the perfusion defect during stress. Then they said a partially reversible defect of the entire inferior wall. So the reversible defect is true, but the inferior wall is wrong, because the place affected we saw is the anterior and the septal area. Remember I said the septal is on your left if you're looking at the image, while the lateral is on your right. So it's an anteroseptal defect. So the main fact they added inferior wall makes the option wrong. Now, a severe predominantly reversible defect of the anterior wall. So that's true, because one, it's majorly the anterior wall, and the defect is reversible, like we saw. A fixed defect of the anterior wall without reversibility, that's false. Because if you have a fixed defect, then during rest, that defect will still be sustained. So that's wrong. Now, fixed defect of the apex and lateral wall. So that one also is wrong. So for this one, I can say I am sure the answer is C. So Dr. Eugene, over to you.
Yeah, I think you have right. Is C. I think we've had quite fortunately over the past days a good explanation on the perfusion studies from our consultants, professors, and colleagues. So I think yes, most of our colleagues will agree with the answer C. So if there are no other contributions, we can go to the 84.
Okay.
We
And
have
we
this.
look at it together because I'm not sure I remember anything about those things. Okay, so we can look at it together. Which of the following statements concerning the cardiac catheterization evaluation of valve orifice area is true? Valve area as calculated by the Gollings formula is inversely proportional to the flow across the valve. Okay. Then accompanying valvular regurgitation will result in a falsely high calculated valve area because actual flow across the valve is less than the flow calculated from the systemic cardiac output. Calculation of mitral valve area typically relies on substitution of a confirmed pulmonary capillary wedge pressure for left atrial pressure. Option D. So please, can you go down a little? Okay. Option D, valve area calculation is more strongly influenced by errors in the pressure gradient measurement than by errors in cardiac output measurement. Okay, so I really can't remember the explanations for these things, but let's go through it together. Dr. Eugene is here. Valve area as calculated by the Gollings formula is inversely proportional. This one, of course, is not true. We remember the Gollings formula, so this one is not true. Accompanying valvular regurgitation will result in a falsely high calculated valve area because actual flow across the valve is less than the flow calculated from the systemic cardiac output. Honestly, Dr. Eugene, I can't remember anything about this. Please, if anybody can help, let the person just help now.
I think if you look at the screen, the area is equal to the flow divided by a constant times the square root of the pressure difference between the valve you are looking at. So it means that the area is directly proportional to the flow, and the flow is the systemic flow, the cardiac output. So if you use that one, then it means that A will be false because it's not inversely proportional. The mitral valve area is directly proportional to the flow. So that will make the A statement false. Now, if you look at the B, it said an accompanying valvular regurgitation will result in a falsely high calculated valve area because actual flow across the valve is less than the flow calculated from the systemic cardiac output, which is not true because the flow here is your systemic cardiac output. So if you have a regurgitation across the valve, it will reduce the forward flow. So your flow will reduce and directly your area will reduce. So that makes the accompanying valvular regurgitation giving you a falsely high calculated area being wrong, but it will rather give you a falsely low area and not high. Let me see. Let me try and mute. I think there's a voice. Hold on. Okay. Now, if you go to C is a state like one. You know, every formula comes with assumptions, and that's one of the assumptions of the formula, which uses your pulmonary capillary wedge pressure as the left atrial pressure. So that one is the correct statement. And if you go to the D, The valve area is more strongly influenced by errors in pressure gradients. Now, if you look at your pressure gradient here, it's a square root, whereas the flow is a direct flow, which is your current, is direct proportional, which is your systemic forward flow and cardiac output. So it means that if you use that, the area will not be strongly influenced by the pressure gradient, but rather more of errors in the cardiac outputs. So that will make the correct answer C.
Okay, Dr. Eugene, thank you. I don't even know if I even understood what he said. I think this one is maths, not just this thing. Okay, thank you.
It's not, so look at it's not difficult. You see, it's a formula. It's a formula the Golden guy brought up, saying the area is equal to your flow. The flow across the valve divided by a constant times the square root of the pressure gradient between the valve. So it means that if flow increases, at the end, the area you're going to get will be a bigger area. If flow reduces, the area you get will be a smaller area. Same as so the denominators here, if they become lower, they are inversely proportional to your area. So the first option A is saying that the valvular area in the formula is inversely proportional to the flow, which is false. The area is directly proportional to the flow, not inverse.
Yes. Yeah.
Then when you go to B, it says accompanying valvular regurgitation will result in a falsely high calculated valve area because actual flow across the valve is less than flow calculated from the systemic cardiac output, which is false because the flow here is your systemic flow, the forward flow across the valve. So if you have regurgitation, you are going to lose the forward flow across that valve. And if the flow is directly proportional to your area, then at the end, your area will become smaller, the area you calculate. Because so that will make the B statement false because it said falsely high. It's rather going to be a falsely low value.
Okay.
Then the C is like every formula comes with its assumption. So that one is a statement of fact.
Okay.
By the guy who proposed the formula so that you can't change, which is a correct. And the D is saying that the valve area calculation is more strongly influenced by errors in the pressure gradient. But if you look at the pressure gradient, the value is halved. It's a square root of that. Whereas the flow is directly proportional to the area. So you have, and your flow is your cardiac output. So an error in your cardiac output will influence the area more, which makes this statement wrong. And that's why the answer is the C.
Okay. Thank you so much, Dr. Eugene. Thank you. Thank you. How sorry. I apologize. Next time I'll do better. I didn't know that this was my question. Sorry.
Okay, so
But I think for someone who didn't know these are your questions, you discussed them quite well. That's my opinion.
I agree.
Thank you.
And she wanted to put me on the spot.
I know I can't go wrong when you're here. So
okay, so do we have, you're welcome. Do we have Dr. Oji Miriam on? I think I saw Miriam on earlier on, but probably. All right.
Yes, I'm still on.
Yeah. Oh, great. Thanks. So we go to 86.
Good evening, everyone.
Good evening.
Okay, I'm going to take number 86 to 19. The question says, a 40-year-old man presents to his physician. With shortness of breath on exertion, peripheral edema, and arthritis of his hand. On examination, his vital signs are normal. His sclera are etheric, and his skin has a bronze hue. Lung examination demonstrate rails at the bases. The carotids are normal upstroke. The cardiac impulses is displaced laterally, and there is an audible S3. His abdomen is distended with evidence of hepatosplenomegaly and ascites. There is peripheral edema. Then the laboratory studies reveal serum glucose of 225 milligram per dl and a transferrin saturation of 70%. Which of the following statements about this condition is true? Please, can you hear me? Am I audible, please?
Yes, please, you are audible.
Yes, ma'am.
Okay, from the questions here now, we can see that this patient has a features of a congestive cardiac failure, and there's also a liver pathology, also has arthritis. Then with the laboratory investigations they gave us, there's evidence of diabetes and the transferrin saturation of greater than 70%. Normally, it's normal saturation, transferrin saturation is between 15 to 50. So this one is showing that there's evidence of iron overload, and it's in keeping with hereditary hemochromatosis. Then the hereditary hemochromatosis is inherited as an autosomal recessive, where you have mutation in HFE. And then the clinical features they present, most times they have a brown skin, which is hyperpigmentation. They can have diabetes from deposition of iron on the pancreas. They can also have a hepatomegaly or hepatosplenomegaly and cirrhosis from iron deposition in the liver. They can have cardiomyopathy. That's a cardiomyopathy. They have the type of phenotype they have mixed, dilated and restrictive pattern. They also have arthropathy. Clinically, classically, it affects the second and third metacarpophalangeal joints. And also, like we talked about, the transferrin saturation is usually greater than 45%. So the ECG findings in iron overload, because of the iron deposits in the myocardium, will have low voltage complexes. That's low voltage QRS complexes. So can we take the questions now? Question A says, it is inherited as an autosomal dominant condition. It's a false statement because it's an autosomal recessive. The cardiac involvement results in mixed, dilated, and restrictive cardiomyopathy. From what I explained before, in hemochromatosis, they have a mixed, dilated, and restrictive pattern. So that makes option B a true statement. Option C says ventricular hypertrophy with increased QRS voltages is the most common electrocardiographic findings. That's a false statement. Because of the iron overload, the QRS complexes are usually low voltage. The echocardiography often shows a thickened ventricle with a granular sparkling appearance. That's a false statement. This is actually seen in amyloidosis. The granular sparkling appearance is seen in amyloidosis. So here the answer to 86 is B. Please, we have contributions and questions. Hello?
Yeah, you are audible, please. You are audible.
So can I go on?
If there are no contributions, yes, please, you can go on.
Okay, please, can you take me to 87? Okay, number 87 says a 55-year-old woman presents for a routine evaluation. On examination, a systolic murmur is noted. Which of the following response to maneuver would be suggestive of mitral valve prolapse as the cause of the murmur? Okay, we said something before about mitral valve prolapse today. So we said that mitral valve prolapse, it occurs, we have some maneuvers that affects it. It's a systolic murmur. So but you have maneuvers that can affect it. When we talk about these maneuvers, first one, they say that isometric grip For option A, with isometric hand grip, the murmur starts early in systole and becomes louder. This is a false statement because in isometric grip, the murmur becomes sometimes inaudible or with decrease. So, and it becomes a delay, it doesn't occur early. So that option A is false. With standing from a supine position, the murmur begins late in systole. So this is also a true statement. They say that in standing, there's going to be decreased left ventricular filling, and that will now increase, makes the murmur to begins for the murmur to begin late in systole. So with that, what occurs in standing from a supine position. Carotid sinus massage increases the intensity of the murmur. Carotid sinus massage actually does not affect the murmur of the mitral valve. Rather, it intensifies the murmur of focal. Valsalva maneuver causes the murmur to arise early in systole. So this one too, the Valsalva maneuver makes the murmur to arise early in systole. Sorry, it's like I'm mixing it up. The Valsalva maneuver makes the murmur to appear. The Valsalva maneuver causes the murmur to arise early. That's also a true statement. Option E says that squatting from standing position moves the onset of the murmur earlier in systole. That one is false because squatting from a standing position moves the onset of the murmur to be delayed in systole. So I made a mistake in option B. With standing from a supine position, the murmur begins early, not late in systole. So from this one now, the correct option here is Valsalva maneuver. We have the Valsalva maneuver and standing. These two maneuvers makes the murmur to begin early in systole. So what makes that option B false is because they said it begins late in systole. Hello, please, contributions and clarifications.
Yeah, so I think earlier on I noticed that you had messed it up, but you corrected it as you said. So essentially, anything that reduces your left ventricular volume will cause the murmur to appear earlier, and anything that increases the left ventricular volume will let the murmur move a bit far from the early part, so maybe mid to late. So like you rightly so, Valsalva maneuvers like this literally are going to reduce your preload and so reduce the left ventricular volume. And that's why the murmur will come earlier. So if you hand grip, for example, increases the afterload, and that indirectly will affect the left ventricular pressures and volumes, and that will cause the murmur to come closer. So just assume anything that you can deduce that will lead to a reduction in LV volume will let the murmur appear earlier in systole, and anything that can increase your left ventricular volume or pressure can cause the murmur to appear late in systole.
Okay, Chief. Thank you. Any other contribution? I can go on to number 88.
Yes, please, if there are no questions or contributions.
Which of the following statements regarding the effect of potassium concentration on the ECG is true? So in hyperkalemia, there are sequence of symptoms, a manifestation on the ECG. Classically, it begins with narrow peak tented T wave with a shortened QRS complex. That's the first feature you see. However, as the hyperkalemia progresses, there's going to be reduced both atrial and ventricular resting membrane potential, which will inactivate sodium calcium channel and decrease the conduction velocity. So at this stage now, you are going to have the widening QRS complex, and the P amplitude will begin to decrease. So at later stage, they can even have S-systole, but these are the classically sequentially how they present. So in the option A says the earlier echocardiographic signs of hyperkalemia is reduction in P wave amplitude. That one is not the first feature. The earliest feature is a tall tented T wave and shortened QRS complex. Shortened T wave, QT interval, sorry. Then we have option B say that deep symmetric T wave inversion is a characteristic feature of hyperkalemia. So that's not a feature of hyperkalemia. Like I've said, we have a hyperkalemia predisposes to digitalis induced tachyarrhythmia. Remembering the mechanism of action of digitalis, which is sodium potassium ATPase pump. So they competitively inhibits the pump. So when you have hyperkalemia, it will not affect the toxicity. However, when you have hypokalemia, the digoxin binds more and can predispose to toxicity. Hence, that one is a false statement. Prominent U wave are characteristic feature of hyperkalemia. This is a false statement. Prominent U wave are seen in hypokalemia, not hyper. QRS complex widening is common in severe hyperkalemia. Okay, this one is a true statement. Option E is the answer, because we said that as the hyperkalemia progresses, we're going to have now widening QRS complex and reduce or absent P wave. Please, contributions and questions, comments.
Yeah, sorry, but as a code to remember the ECG features of hyperkalemia, there is this pull and push effect. When you pick that T wave and you draw it up, it drags all those waves, you drag it along, meaning that once you have a taunted T wave, once you drag it, the QRS complex will be widened and the amplitude will be low. The P wave we also widens or almost absent, and there will be prolongation of the PR interval. And if you look at the effects of hyperkalemia on the SA nodes, because it deprives the SA node, they come with all these brachyarrhythmias too. And at the time, you see them developing asystole or even ventricular fibrillation at the long run.
Okay. Thank you, Chief. Can I go ahead?
Hi, sorry, I just wanted to add something. So with hyperkalemia, we all know that the first thing is the tall tented T waves. Then from there, the atria become paralyzed, and then the ventricles also become paralyzed. So in mild hyperkalemia, you would have just a tall tented T waves. When it gets moderate, the atria become paralyzed, so PR starts to prolong and P starts to flatten. Then the ventricles in severe form start to get paralyzed. So then you have QRS prolongation to a sine wave, and then you have all the ventricular arrhythmias that may occur. So that's another way that we can think through it, so that if there are any questions on any of the various stages of hyperkalemia, we can reason it out and then choose the right answer. Thank you.
Thank you, Chief. Any other contribution, or can I go ahead? Okay, question 89 says, which of the following conditions can result in significant electrocardiographic Q wave in the absence of infarction? Okay, there are some conditions that can produce Q wave in the absence of infarction, they are called a pseudo infarct. So we have the following conditions. It can occur in altered ventricular conduction, people with ventricular enlargements, left bundle branch. It can also occur in Wolff-Parkinson-White syndrome, left atrial fascicular block. So coming to our question now, they said the following can produce a Q wave. We have right bundle branch block. Right bundle branch block does not produce a Q wave. However, left bundle branch block can produce a pseudo Q wave. We have a small left ventricular size. Small left ventricular size may interfere with the QRS complex, but does not typically affect the Q wave. So that one is not part of it. So we have acidosis. Acidosis can also affect a conduction system and even repolarization, but it does not have any effect on Q wave. However, Wolff-Parkinson-White syndrome can produce a pseudo Q wave because of the pre-excitation pathway. So the answer to number D, so number 89 is D. Contributions and comments, please. Hello?
Yeah, you are audible. Waiting for contributions, please. Can anyone offer an explanation why the Wolff-Parkinson-White causes the Q waves?
For Wolff-Parkinson-White, I think it depends on the location of the accessory pathway. So, for example, a right-sided pathway will give a left bundle kind of morphology in the V1, and so it could result in a kind of Q wave of some sort. I'm not sure if that's the exact explanation, but then I know that's one way of looking at it.
Okay.
Thank you for the
Thank you.
contribution.
Thank you, Kofi. All right, so you can go to 90.
Okay, number 90 says, which of the following statements regarding interpretation of exercise electrocardiography is true? Okay, says the presence of right bundle branch block does not alter the sensitivity of exercise electrocardiography for the diagnosis of myocardial ischemia. So right bundle branch block can actually alter it, it may reduce the sensitivity of exercise ECG for detecting ischemia, especially if it occurs in lead 1 to V1 to V3. as the baseline changes, it can obscure the exercise-induced ST segment changes. So if you have right bundle branch block in leads V1 to V3, it can alter the sensitivity, because now it will alter the baseline, making it obscuring the ST segments changes that could occur during exercise. So that makes that option A false. B says that ST segment depression in the inferior leads during exercise testing are specific for significant right coronary artery disease. This one is also a false statement, because ST segment depression in inferior leads during exercise testing are not specific, because other things can produce ST segment depression apart from right coronary artery. So it can be caused by ischemia in other regions. It can even be by non-cardiac cause factors. So you can have ST depression in inferior lead that is not due to right coronary artery disease. So that makes that option B false. It's not specific for right coronary artery disease. Then C says the location of ST segment elevation during exercise testing predicts the anatomical site of clinically advanced coronary stenosis. That's a true statement. Exercise-induced ST segment elevation in leads associated with specific coronary artery disease territory, like when you have anterior leads for left anterior descending artery, correlates with the severity of the stenosis of the disease. So when you have the ST segment depression in specific anatomical position, it can correlate the severity of the disease. So that makes option C correct. D, digoxin therapy is not associated with false positive finding on exercise electrocardiography if the baseline segments are normal. That one is also a false statement, because they said that digoxin is associated with a false positive finding on exercise ECG due to its characteristic effect on ST segments, which can present even with normal baseline ST segment morphology. So with digoxin, they can even occur with the normal baseline morphology, apart from those ones that have ST segment depression. So that makes option D false statement. The answer there is C. Please, contributions.
I think this localization on ECG by stress is quite common. I think this is about the second or third time the ST elevation localization has repeated itself. So we may have to take note of that. And the digoxin too. I think there was a question earlier too on the digoxin and stress test.
Okay.
Please, any contributions? Do we have let's see, sorry, that's okay. If we don't have any question, Dr. Felix Awindago will continue for us.
All right, so thank you, Eugene. Good evening, everyone. So I'm taking question 96 to 100. 96 to 100. So 96 to 100 says match each of the following clinical scenarios to the most likely cause of syncope. So this question is essentially testing our skills on the causes of syncope. So we have these categories, particular causing a syncope.
Alex,
So
we seem to be
generally,
losing you a bit, the network.
hello, can you hear me?
Yeah,
Is it better now?
It's better now, yes.
Yes. So in ventricular syncope due to ventricular tachycardia, complaints of rapid death, those individuals they
Yeah, Alex, it's still a bit difficult to hear you.
I think it's a network.
Okay.
Using my phone. Is it better?
Okay, I don't know how. Can any other colleague also respond? If they are okay with
It's
it,
not.
fine.
It's not. It's not at all.
His audio is poor from my side.
And maybe, I don't know, I'm using an earpiece. Maybe that may be causing. Yeah, I mean, Felix, if you're using an earpiece, that may be causing your voice to sound far away.
Okay, so let me try. Hello? Hello?
Yeah, this is better. This is way better.
This is better.
Yeah.
Okay. All right. So I was saying that in syncope due to ventricular tachycardia, usually as of rapid onset, tends to occur without prodromes. Usually if there's a prodrome, usually the short duration, usually palpitations. And typically there's a background history of coronary artery disease and would occur in mostly older adults. Then recovery is usually quite rapid in those individuals. So when they recover, they are usually back to normal behavior and orientation. If we look at high degree atrioventricular block, also of cardiac origin, but they usually tend to have initial symptoms or signs before they develop syncope. They tend to have prodromes such as dizziness, lightheadedness, and then with time they might have syncope or they would faint. Epilepsy also abrupt, but then they might have a prodrome, an aura, before the seizure would occur. And typically, you probably would see epileptiform movement, tonic-clonic seizures, and other characteristics. And they might have incontinence of bowel or bladder. There is also foaming and probably tongue bites. So that is usually quite specific. And they usually will not wake up immediately. The recovery is usually a bit delayed up to about 5 minutes, where they have the postnatal phase. Neurocardiogenic syncope or neurally mediated usually would be associated with some emotional events, or usually fright, fear, or they might be associated with some emotional activity. Commonly, people who would see blood tend to blood. So that is also quite common. And from literature, is actually the commonest cause of syncope, contributing to up to about 50%. And then I think the last one is the hysterical fainting, which occurs more commonly in females. And reading through literature, it's in younger individuals. And usually you really cannot identify a trigger. And they tend to happen when people are usually around. And usually they recover without residual symptoms. So if we look at the answers, let's go. Okay, so we'll go through this. A 79-year-old, 73-year-old, it's gone. Can you go up? Okay, all right. So a 73-year-old with a remote history of myocardial infarction feels the onset of palpitations while driving, then awakens having driven his car into a ditch unaware of what has transpired. So from a description of the etiologist, this is most likely a ventricular tachycardia. Then 97, a 25-year-old woman on chronic anti-seizure medications becomes warm, diaphoretic after donating, and very pale after donating blood, then suffers frank syncope while seated upright in a chair. After being held to the floor, she awakens embarrassed and then alert. Embarrassed and then alert. So the history, with a history of chronic anti-seizure medication, I think is a red herring, just to divert our thoughts. But looking at what the patient went through, warm, diaphoretic, very pale after donating blood, that would be a neurally mediated syncope. So that would be a neurocardiogenic syncope. Then the third is a 73-year-old woman with recent episodes of dizziness, begins to feel lightheaded while seated at church, then within seconds turns pale and slumps to the floor with a few clonic jerks. She regains consciousness 1 minute later, completely aware of where she is, and asks what has happened. What has happened? When an ambulance arrives, her blood pressure is 108/70 and heart rate is 60 beats per minute. 60 beats per minute. So we'll look at the options, and the history again. There's onset of dizziness, lightheadedness while seated before she slumps. And she also wakes up quite alert. So this mostly of cardiac origin. So this would most likely be a high degree atrioventricular block. And just to add that for some of these patients, sometimes because of the hypoxia, they would have some few clonic jerks, which would mimic an epileptic form or an epileptic seizure. So let's be wary of that. A 32-year-old man with a history of prior syncope notices an odd odor, after which he falls to the ground. He awakens 3 minutes later, confused, disoriented, and is found to be incontinent of urine. So again, this is highly suggestive of a seizure, epilepsy, and we can see that from the aura odd odor, falls to the floor, awakens 3 minutes later. So a post-ictal period, and then is confused and disoriented. And in addition, is incontinent of urine. And then the last one, an 18-year-old army recruit falls to the ground while standing at attention for 20 minutes during his first week of basic training. First week of basic training. He immediately awakens, feels a bit groggy, but quickly is able to rejoin his squad. So again, standing for 20 minutes, not used to that, would have pooling of blood, the lower limbs, hypotension, and then that is usually a sort of a paradoxical reflex. This leads to syncope in this young man. So that's urocardiogenic syncope in this area. Any point of clarification, additions?
I think it's based on the descriptions and explanations. Yes, I agree with you. But I was just wondering, can strong odors also induce vasovagal response?
So anything that can, I'm not sure about the strong odors, but anything that would affect the emotions. So fear, panic, extreme fatigue, closed areas, anything at all can usually lead to a vasovagal or neuro cardiogenic syncope. And that is usually, when I looked at literature, you tend to have an afferent limb and then the efferent. So the cause or the pathophysiology of the syncope is usually from the efferent. So usually you would have, once it will affect the vagal system and increase the vagal tone, you tend to have withdrawal of the parasympathetic. And then there is hypotension, and then the bradycardia and the syncope can happen. So it's possible, but I'm not too sure. Yeah.
Well, from the pathophysiology, from what you explained now, it can actually cause. There are so many unpleasant things that can cause neurally mediated, like even sound, sight, smell, different emotions that they can all cause neurally mediated symptoms. With one of them. Thank you.
Thank you.
Okay, thank you. We have about 15 minutes more. Currently, the other colleagues have not been able to respond, so I had to get Felix to step in. But we have 15 minutes. I think we can take 91 on our own and see whether we can do it, and we close. If I have consensus, I can lead a discussion from 91 to 95. Okay, so for 91, a patient, or if the person for 91 is here, I've been checking, but 91, Ilona, Ifoma, I don't think she's here. I've checked, I've not seen her name. Or if there's anyone on who has done his part, his or her parts, even though we are not there yet, I can go to that part, then we can clear that one. Do we have anyone here who has done his questions, but we are not yet to get to him or her? Okay, so we can take the 91. So 91, a patient underwent echocardiography as part of evaluation of exertional dyspnea. Figure 1.22 displays an image from the continuous wave Doppler interrogation across the mitral valve obtained from the apical long axis view. Which of the following statement is true? So if we look at the image, clearly we see the continuous wave spectra of the mitral inflow. And if we look at it, we see the E and A wave are fused. There is no clear distinction between the E and the A wave in diastole, even though we see the early filling component, the E component, and the atrial component. Then we have a mitral regurgitation occurring. So now on the side, if you look at the peak velocity of the E, you could see it is above the value of 2. So the first one says the early diastolic peak velocity of 2.7 is within the normal range. We all know that a value of above 2 is suggestive of a mitral valve stenosis. So clearly a value of about 2.7 will not be normal. You can have the value increasing, not necessarily in valvular stenosis, but in increased flow, especially when it is mild, between 2 to 3. It is not always that it is due to a stenosis. So you may have to also look at it clearly before you conclude you are dealing with a stenosis. And if you think there's a stenosis, there are objective ways of assessing the mitral valve area and also the gradient across the mitral valve to define it as severe or not, in addition to other parameters such as the presence or absence of pulmonary hypertension. So A will be a false statement. There is an abnormally delayed decline in the transmitral velocity signal during diastole. And if we look at the filling here, the flow across the valve, you can clearly tell that this slope, which is the diastolic filling, the E, you can see that there is delayed. The slope is not steep and it runs into the A wave. So that will make the statement there true, that there's an abnormally delayed decline, the transmitral velocity signal during diastole. And there's no evidence of regurgitation, which is false, that clearly there's an evidence of a mitral regurgitation, as we could see there. And the D says, with color Doppler imaging, the extent of mitral regurgitation can be overestimated if the regurgitant jet is directed eccentric along the left atrial wall. So rather, eccentric jets are likely to be more underestimated when it comes to regurgitation. And if you look at the various means of estimating the severity of regurgitation, is based on an assumption of a central jet. If you look at the PISA method and the others, it assumes the jet to be central. For example, if you decide to use the continuity equation to evaluate and calculate your valvular area or the regurgitant volume, you will notice that the formula is based on an assumption that you have a central jet, because you are going to trace also in addition the jet area. And if it is not central, that formula really does not hold, especially when you are using a continuity. So that is a false statement. So the correct answer will be B. There's an abnormally delayed decline in the transmitral velocity signal. Please, are there any additions, subtractions, corrections? Yeah. So will someone want to take 92? Read 92. They say, which of the following statement regarding commonly used quality improvement strategies is correct. This, I think, will probably leave it for the assigned person to come and give explanations to make it clearer. I don't have much concepts in that area, so I can skip it. Then we can go to 93. 93, we have a 25-year-old man who died suddenly whilst jogging, and a post-mortem examination was performed. A histologic section a histology section of the left ventricular myocardium is shown in figure 1.23. Which of the following statements is true? So we have a 25-year who dies suddenly whilst jogging. We are concerned about sudden death. So we are looking at that this patient has any predisposition to an arrhythmia. Is this patient have an LVOT obstruction whilst jogging? So was it HOCM? Was it hypertrophic cardiomyopathy? Does this patient have an arrhythmogenic right ventricular disease? Does this patient has long QT syndrome? Things that predispose patients to arrhythmias that can lead to sudden death, Bugada, and etc. That is what should be running through our minds. So you go through the options, but specifically this is looking at the myocardium. And if you look at the image, sorry, okay, if you look at the image, clearly you could see that the cardiac myocytes are in disarray. The arrangements are chaotic with a lot of fibrosis in between them. So if you look at the history, muscles in disarray, fibrosis, sudden death, 25-year-old, it's likely we are dealing with hypertrophic obstructive cardiomyopathy, especially when it happened on exertion during jogging. So that is something we should think about. So if it is a HOCM, they said the histology findings are of normal myocardium, which is not true. That will be false. The condition is inherited as an autosomal dominant trait, which is true. HOCM is inherited by autosomal dominant. And this is a disease of plasma membrane protein synthesis. No, it's not of the plasma membrane, it's of the myocytes and the myosin and actin components of the muscle. The greatest risk to affected patients is the development of complete block, is a sudden death from ventricular arrhythmias. One specific gene mutation has been identified that accurately predicts sudden cardiac death in the majority of patients with this disorder. We all know that there are several mutations that have been associated with HOCM, and it's not one specific gene mutation. So I think our time is almost up. We'll just end it here, and hopefully we'll get our colleagues to do the backlog and brush up these parts if the person allocated to shows up tomorrow, God willing. On that note, if there's any senior person who wants to make any remarks, I think Dr. Okopi said he was in a meeting. If there's any senior person on who wants to make a comment, kindly go ahead. Dr. Quirky, I don't know whether he's still on. They could hear me.
I am just coming back actually, and sorry I've been out because I had a meeting this evening. But again, so yeah, so I don't know where to start from, but just to say, let's keep on the spirit and let's continue the commitment. Again, I encourage everyone at all times to be part of it because really, this exam is about talking. So the more you talk on the platform, the more you are confident with the stuff. I used to say that if you don't talk now, on the day of the auras, you will surely talk. So just be part of it. Great job, Dr. Eugene. Great job, the team. thank everybody for the commitment.
So thank you very much. So we'll continue, God willing, tomorrow. Have a
All right.
wonderful evening.
All right. Bye.